All right, next we're going to talk about the Prognosis Nutrition Index, or PNI. So the Prognostic or Prognosis Nutrition Index is an objective assessment reflecting the immune nutritional status of patients, but mostly immune. Not great on nutritional status, but it is a good indicator of soft tissue sarcoma, renal cancer, liver cancer, lymphoma, and COVID severity. So how we calculate it is we need serum albumin, triceps skin fold, and transferrin. So think about why we would want these. Remember that albumin is the workhorse of the body. It's a colloidal protein, so it's going to do water balance, but it is also a negative acute phase protein. Likewise, transferrin is a negative acute phase protein. And the triceps skin fold is a measure of, or can be, a metric of muscle mass. More so, though, it's the mid-arm muscle area or mid-arm muscle circumference. So we take albumin, triceps skin fold, transferrin, and delayed cutaneous hypersensitivity to mumps, candida, or SDK. This is just a measure of if there's a reaction or not, basically. So the prognostic nutritional index is a good way of measuring if someone is going to die in the ICU. It's not a great index, though, for actual nutritional status. All right, so we're going to move on to type 2 diabetes. So we know we're all familiar with type 2 diabetes. Screening for prediabetes and type 2 diabetes with an informal assessment of risk factors or validated tools should be considered even for asymptomatic adults. So this means that basically almost everyone should be screened for type 2 diabetes. Testing for prediabetes and type 2 diabetes in asymptomatic people should be considered in adults of any age, but especially those with overweight or obesity, and those who have one or more additional risk factors for diabetes, and we'll go into those. And testing for prediabetes and or type 2 diabetes should be considered in women planning pregnancy with overweight and obesity, or who have one or more additional risk factor. But for all people, testing should begin at around 45 years. If tests are normal, the repeat testing can be carried out a minimum of 3-year intervals. In patients with prediabetes and type 2 diabetes, it's important that we identify and treat other cardiovascular risk factors. For children, risk-based screening for prediabetes and or type 2 diabetes should be considered after the onset of puberty. And you may be wondering why. Puberty is a naturally occurring period of insulin resistance. So everyone becomes insulin resistant during puberty, but for some reason, some people don't regain insulin sensitivity. So in adolescents and children with overweight and obesity, they should be screened for prediabetes and type 2 diabetes either after the onset of puberty or after 10 years of age, whichever comes first. So some risk factors that can signal diabetes: polydipsia, polyuria, unexplained weight loss. These are for all types of diabetes. So type 1 or type 2. Other risk factors, hypertension or on therapy for hypertension, high density lipoprotein, cholesterol less than 35 milligrams, high fasting triglycerides, treatment with atypical antipsychotics or glucocorticoids, overweight or obesity, or a casual, meaning non-fasted, over 200. These ones, this is type 2 diabetes, not type 1. So this is a nice link. Here we can, I think, open it. So this is the diabetes risk test. Click here to begin. Goes NIH. I'll say I'm doing it for someone else. I'll pretend I'm doing it for my dad. I think he's older than 60. He's a man. Not that I know of. And he's about, 5'11". Oh, email. View results. So, high risk. Even though he didn't meet all of the criteria, he's still at high risk. And let's go back to the PowerPoint. So these are the criteria for diagnosing prediabetes and diabetes. So we can use A1C, also known as hemoglobin A1C. And that if an individual has a hemoglobin A1C with between 5.7 to 6.4%, they have prediabetes. Prediabetes is a lot like overweight. It's not diabetes, but it means you're at risk for diabetes. And then a HbA1c greater than 6.5 indicates diabetes. We also can look at fasting plasma glucose. So around 100 to 125, that's indicative of prediabetes. Greater than 126, diabetes. We also can do oral glucose tolerance tests. You'll see this a lot for pregnant women. But a test value of around 140 to 199 or above 200 is indicative of prediabetes and diabetes, respectively. And we can't test prediabetes with a random plasma glucose because this is non-fasting. But above 200 milligrams per deciliter is indicative of diabetes. So we have a lot of different ways of diagnosing diabetes because we actually have to have 2 measurements to confirm a diabetes diagnosis. So let's look at this decision pathway. First, we need to identify patients at high risk for developing diabetes. So that could be overweight or obese BMI. Ugh, sorry, let me rewrite that. It could be overweight or obese BMI. Could be high triglycerides. It could be hypertension. Or age greater than 45 years. Okay, so we know who we should screen. The next is choosing a screening method. Usually we're going to start with either the fasting plasma glucose or A1C. A1C is probably even easier because you don't need to be fasted. So test someone's A1C. If it's 5.7 to 6.4, the person may have prediabetes. If the person has a A1C greater than 6.5, they may have diabetes. But to diagnose diabetes, we need to confirm the diagnosis with a second measurement. And that second measurement might be a fasting plasma glucose or a 2-hour glucose tolerance challenge. So what test to use? We have that fasting blood glucose, random plasma glucose, and an A1C, as well as an oral glucose tolerance test. The oral glucose tolerance test means that you have a fasting blood draw. BD means blood draw. You then drink some glucose, and then you have a 1-hour blood draw and a 2-hour blood draw. Usually, you'll use an IV catheter for multiple draws. But the patient should be active and eat a regular diet that includes at least 150 grams of carbohydrates daily for 3 days prior to the test. The patient should be instructed not to eat or drink anything except for water for 8 to 12 is what I usually recommend, but not more than 14 hours of fasting. And the patient should discontinue, whenever possible, non-essential medication, including things like supplements. So, like I said, you get a fasting blood draw. A rule of thumb is a 75-gram glucose bolus, but you can also dose it by weight. And then draw blood after 2 hours. Research draws will often include a 30-minute, a 1-hour, a 90, and a 2 hours. But for the diagnostic, you just need that 2-hour value. And the oral glucose tolerance test is particularly useful in patients with borderline fasting and postprandial glucose. Borderline fasting levels that may be indicative of type 2 diabetes, and it can be used to support or rule out diagnostics. The OGTT, though, only establishes the presence of a glucose intolerance, meaning that we're unable to take up glucose. We can estimate insulin sensitivity, but we can't directly measure it. And the glucose tolerance test won't tell us about the specifics and sensitivity of the complications of diabetes mellitus. So things to keep in mind, though, there is a slight hyperglycemic effect seen in patients on oral contraceptives. Failure to have the patient on a 3-day high carbohydrate diet may result in a false positive oral glucose tolerance test, although most people are on a high carbohydrate diet. And importantly, impaired glucose tolerance is not equivalent to diabetes mellitus. And a normal result doesn't ensure that diabetes will not subsequently develop. So how do we confirm a diagnosis? We can repeat the same test or choose another test. But the second test should be done immediately, meaning they shouldn't go home, wait a couple months, and then get a second test. If the two tests agree, consider the diagnosis confirmed. If the two tests don't agree, repeat the test that was above the diagnostic threshold. So if you do a fasting plasma glucose and an A1C, but only the A1C was above the threshold, redo that one. So this table, again, is just going to show you the uses of the different tests. So this is fasting plasma glucose, technical features, and some pros and cons. So again, this is just the criteria for testing for diabetes or prediabetes in asymptomatic adults. But here's our risk factors. Um, Patients with prediabetes should be tested yearly. Women who were diagnosed with GDM should have lifelong testing every 3 years because GDM is associated with type 2 diabetes later in life. For all other patients, testing should begin at 45 and repeated at 3-year intervals. In children and adolescents, we still don't have a good handle on this. Some consider that youth with overweight and obesity who have one or more additional risk factors, such as maternal history of diabetes, a family history of type 2 diabetes, race or ethnicity that is associated with having high diabetes, or signs of insulin resistance or conditions associated with insulin resistance. So, acanthosis niagrans, this is dark spots on the back of the neck. Hypertension, dyslipidemia, polycystic ovarian syndrome, or if they were small for gestational birth weight. And finally, some classifications for hypoglycemia. So if glucose is less than 70 milligrams per deciliter, that would be level 1. Level 2 would be less than 54 milligrams per deciliter, and level 3 is a severe. If it's under 54, uh, that would be a severe event characterized by altered mental and or physical status requiring assistance.